Not installed.
Hello, good morning, everyone. Good morning.
Good morning, ma'am.
Good morning.
Good morning,
ma'am.
How are you?
How are you? I'm fine. We are fine,
Great.
ma'am.
Great,
How are you,
great,
ma'am?
great, good.
Morning, Mimla ma'am.
Good morning.
Good morning, madam.
Good morning, dear. I think there was some technical issue, isn't that? So some problem was there?
It's resolved
Yes,
now.
Yes.
It is. Hi, Hamza. How are you?
Yes, I'm fine, ma'am. Yes.
Good to see. Where is Suresh? I can't see him.
He may be joining. He was also out.
And because I think they said the cap is 100.
Mhm.
So probably that was the reason. But
Yes.
doesn't matter. I think sometimes these problems come.
Mhm.
Good morning, Hamza sir.
Morning, ma'am.
morning, Alka, ma'am.
Good morning, ma'am.
Hi, Alka. Acha, I saw Alka already.
Good morning. Good
Alka is in court, no?
morning, ma'am. I said good morning.
He's in the office, probably.
Outside of office.
Outside of office? Okay.
There is one place
Oh,
outside near staff room where I was because network
Okay.
problem. I've been office.
Okay.
If everybody is in, then I think we can start now without this. But Dr. Rakesh sir is not okay.
Good morning, Hamsika. I have joined. Okay.
Yes, Stella ma'am. Yes, I saw. And you have to leave also, no?
Yeah.
Yes. At 12. We'll ensure.
Yeah, if I could
Rakesh
finish
sir
by
also
11:30,
joined.
it will be good. Yeah. By 11:30, if I finish, it will be good because I can have my lunch and then leave.
Chilla, you are going to have lunch so soon? 11:35?
No, I have to leave from here. I have to go to Katpadi. It takes about 2 hours from here. Yeah. It's by road. So I have to leave soon.
Dr. Rakesh Garg sir has also joined. Rakesh sir, good morning.
Hamza, I think we can start then, if it's okay.
Yes, of course. Yes,
We ask Madam Principal.
Nirul.
Yes, ma'am. 2 minutes. Yes, ma'am. 2 minutes. We'll start, ma'am.
Okay, no problem.
Yes, thank you.
Good morning, all dignitaries. Madam Achala, madam, have joined.
I heard her.
Yes, one Achila Kumar's one name is there, ma'am.
Very good morning to all of you.
Good morning.
Good morning.
Good morning.
How are you, Achila?
I'm fine, ma'am. Thank you. How are you, ma'am?
Great, good. Good to see you, huh?
Yes, sir.
Saturday morning, because all the week you people are so busy in the ministry.
Yes, ma'am.
But I'm sure people are looking forward to you and Deepika, to contribute to nursing profession a lot. So
Yes, sir. Yes, ma'am. Definitely. We'll try our best to do.
any news about the
something,
bill?
ma'am.
Any news about the bill? NNMC bill?
Not yet, ma'am.
Because they are saying that the winter session will be over by 23rd of December. So there are hardly any days.
Uh-huh.
They have
Ma'am, it is
reduced
in the process, yeah, ma'am.
Okay.
They are doing it, ma'am. We'll follow up it. It
Okay.
is in the process.
I thought by the time they start.
Good morning, everyone. We are going to start, ma'am. Shall we?
Please.
Thank you. A warm and pleasant good morning to one and all present here. Our invited special guests of honor, invited dignitaries, and all the delegates. We are happy to have you all here. It is great joy that your presence has brought to us. I kindly request to all the participants, please fill the pretest form. Before we proceed, I would like to introduce ourselves. I am Patel Priksha, and along with me, Prajapati Hetri from first year MSc Nursing, Sri Vinoba Bhave College of Nursing, Silvassa, Dadra and Nagar Haveli. We are immensely pleased to be a host for today's virtual national campaign on palliative care, an update sensitization program for nursing fraternity. Palliative care is the synonymous with comfort. It improves quality of life of the patient as well as their caregivers when they face the challenges associated with chronic and life-threatening illnesses. The global need for palliative care continues to grow as a result of aging population and rise in a burden of non-communicable and some communicable disease conditions.
We share the extreme joy that we have in extending you all a very warm welcome on behalf of esteemed institute, which are DNIT Care, that is Delhi's National Initiative in Palliative Care, Nursing Scholar Society, and presenting host Sri Vinoba Bhave College of Nursing, Silvassa. It has been a collaborative effort for this renowned institute to come together for a very informative and virtual national campaign on palliative care and update sensitization program for nursing fraternity. We have amongst us, as mentioned before, an institute with the mission to care patients who require palliative care, that is, DNIT Care as an institute who aims to the development of sustainable cost-effective system of the palliative care with active community participation, long-term and life-limiting illness. They work with competent nurses and doctors to support this initiative, and we are joyous for the collaboration we have today for this virtual national campaign on palliative care. Nursing Scholar Society, whose overall aim is to encourage and recognize the scholarly skill of nurses, and promote professional nursing activities and help nurses to lead a quality of life has been always a support for such activities and help the nurse to lead a quality of life and which has been a support for such kind of informative conferences to impart latest and advanced knowledge related to the nursing paradigms in order to help the nurses to have achieved optimal standards in nursing practices. We are joyous for the collaboration we have today for this virtual national campaign.
Sri Vinoba Bhave College of Nursing, Silvassa, has been a center of nursing education from quite a long time and has covered a milestone in achieving a better standard in both nursing education and nursing practices. Sri Vinoba Bhave College of Nursing has its deep-rooted values in educating and the underprivileged community in the tribal areas and has achieved in providing best nursing education throughout these years. Sri Vinoba Bhave College of Nursing, Silvassa, being the host today, now I welcome the organizing chairperson of today's program, Madam Professor Mrs. Niru Patel, Principal Sri Vinoba Bhave College of Nursing, Silvassa, to kindly come on board to welcome our dignitaries. Over to you, Madam.
Thank you, students. A very warm good morning to one and all present here. On behalf of organizing committee, I take this opportunity to welcome you all for this virtual national campaign, organizing by Sri Vinoba Bhave College of Nursing in association with Nursing Scholars Society and DNIP Care on palliative care to sensitize nursing fraternity about palliative care. I heartily welcome our inaugural guest, Mrs. Achla, Assistant Director General Nursing, Ministry of Health and Family Welfare, Government of India. Gave us valuable time from her very busy schedule. A gracious welcome to our special guest, Dr. Vimla Kapoor, the Chairperson Committee of the Expert National Nursing and Midwifery Council and former Director, School of Health Sciences, IGNOU. It's indeed pleasure to welcome guest of honor of today's program, Dr. Alka Tajne, Secretary, Nursing Scholars Society and Principal, Vibrant Nursing College, Surat. I heartily welcome Mr. K.V. Hamza, General Secretary, DNIP Care, who initiated this program on palliative care. Because of him, we are now the part of this campaign. I welcome all the eminent speakers of this program. Dr. Rakesh Garg, Additional Professor, IRCH, AIMS, New Delhi. Mrs. Alistair La Virginia, ex-MNS, National Faculty, Indian Association of Palliative Care and Master Facilitator of End of Life Nursing Educators Consortium. I welcome Ms. Anu Xavier Thali, Nurse Consultant, Department of Palliative Medicine, Mahatma Gandhi Medical College and Research Center, Pondicherry. I heartily welcome Mr. Suresh TP, Secretary, DNIP Care. I am very delighted to welcome all the participants from all over the country. Palliative care, where we cannot change the end outcome. Yes, but we can influence their journey. It's time to care for those who once cared for us, and that is the highest honor we can give to them. I hope surely you all will get different view and beliefs on palliative care after these sessions. Once again, welcome to all of you, and thank you to each and everyone to join with us for this program. Over to you.
Thank you, ma'am.
Light is the most universal and fundamental symbol. Light is knowledge. It is a creative force and cosmic energy. Now, we are moving forward to a virtual lamp lighting ceremony.
Is there some problem? Because we cannot hear.
Ma'am, we are going to connect it again, ma'am.
Thank you.
Shall we go ahead, students?
Yes, ma'am. Now, I welcome on board the Joint Secretary of today's program, Madam Professor Dr. B. Baju Karasi, Department of OBG, SP Begon, to proceed with the inauguration ceremony.
Thank you, Hetty. A very good morning to one and all present in this virtual platform. I welcome Madam Achala, Assistant Director, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, for the inaugural speech. I just would like to brief about Madam. Madam Achala is specialized in MSc in Pediatrics from RAK College of Nursing and a PhD scholar. She is having 28 years of experience in the pediatric, and she worked in KSH Hospital, New Delhi, and she served various heads. She worked as a nursing superintendent, and her professional achievements include she's a National Florence Nightingale Awardee in the year 2019 by Honorable President of India, and she has been awarded for outstanding services and contributions to improve national neonatal care by IFTB in November 2014. And she has been a master trainer and TOT for newborn resuscitations program. She has been a master trainer in Daksh, and she has been trained the many people for in infant and young child feeding counseling by BPNI, Breastfeeding Promotion Network of India. And her enormous work towards the quality improvement initiative, especially Lakshya and other accreditation, is well renowned. And she is a national quality improvement coach from NQOCN, Nationwide and Quality of Care Network. And it's our honor to have you in this platform, Madam. I welcome you for the inaugural speech, Madam. Over to you, Madam Achala.
Thank you so much for the nice introduction. Very good morning to one and all. Greetings from the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. It's my proud privilege to be amongst you all on the occasion of virtual national campaigning on palliative care and update sensitization program for the nursing fraternity, and organized by Shri Vinoba Bhave College of Nursing, Silvassa, in the Union Territory of Dadra and Nagar Haveli and Daman and Diu, in association with Nursing Scholars Society and DNIP Care. Respected dignitaries, Professor Neeru Patel, Principal Shri Vinoba Bhave College of Nursing, Silvassa, Professor Dr. Bimla Kapoor, Chairperson, Committee Expert, National Nursing and Midwifery Commission Bill 2020, and she is a former director, School of Health Sciences, IGNOU. Dr. Alka Tajne, Secretary, Nursing Scholar Society, Principal, Vibrant College of Nursing, Surat, and Mr. K.V. Hamsa, General Secretary, DNIP Care, and all the faculty and my dear students. It is a great opportunity to be with you all today As the theme of today's online virtual conference, it is really very relevant to today's scenario, and it is the need of the hour. As the palliative care, it improves the quality of life of patients and their families who are facing the challenges associated with life-threatening illness, whether it is a physical, psychological, social, or spiritual. The quality of life of caregivers, it improves as well. As we know in the worldwide also, the palliative care received by the needy people is really very less. So the adequate national policies, programs, resources, and training on palliative care among the health professionals, it is urgently needed in order to improve the access to palliative care. The global need for palliative care will continue to grow as a result of aging of population and the rising burden of, as we can see, there are non-communicable diseases and some of the communicable diseases are also there in which the patients really need the palliative care. So the early delivery of palliative care, it reduces the unnecessary hospital admissions and also the use of health services. Palliative care involves a range of services delivered by the diverse cadres of professionals. So it is a kind of multidisciplinary approach in which all the physicians, nurses, pharmacists, or even the physiotherapist and other support workers, and there is a role of volunteers also. They can also help in the support of patients and the families. While addressing the sufferings, it involves taking care of issues beyond the physical symptoms. Palliative care uses, as I mentioned, it is a team approach to support the patients and their caregivers. So this includes addressing their practical needs and also providing the bereavement counseling also. That is also a very important aspect also to support the patients as well as their families. So the palliative care, it is also recognized under the human rights to health also, and it should be provided through person-centered and integrated health services that pay special attention to the specific needs and preferences of the individuals. So palliative care is required for a wide range of diseases. As we know, in the population of adults, they need the palliative care with the chronic diseases such as we know the cardiovascular diseases, cancer, chronic respiratory diseases, patients with the AIDS, with the diabetes, and even we can see the patients, those who are in the last stages of kidney failure, chronic liver diseases, multiple sclerosis, and even the cases of Parkinson's disease also, and with the neurological diseases and some of the congenital anomalies also, and the patients with the drug-resistant tuberculosis also, they really need this palliative care. So the pain and difficulty in breathing, these are two of the most frequent and serious symptoms which are experienced by the patients in need of the palliative care. But we can see there is an insufficient access to the palliative care. When we can see in the worldwide, a large number of patients, they find significant barriers, but we need to overcome these barriers to address the unmet needs of the palliative care. So as we can see, the national health policies and systems also, they do not include sometimes the palliative care. And it's really important to have a training on palliative care for the healthcare professionals, as it is in today's scenario, it is very little. But your institution has taken a really very good step for the sensitization program, so that the very large number of people on this virtual platform, large number of audience can benefit from that. And we can see the lack of awareness among the policy makers also, health professionals and the public. They are also having very less information regarding the palliative care. And we can find some of the cultural and social barriers also because of the beliefs system of the people regarding the death and dying. And also they are having the misconceptions about the palliative care, such as that it is only for the patients with cancer. The people will thought that it is only for the last weeks of the life, and some kind of misconceptions that improving the access to opioid analgesia will lead to increased substance abuse. So what can be done? What we can contribute in that way? Like national health systems, they should include the palliative care in the continuum of care for the people with chronic and life-threatening conditions. So the national policies and strategies to develop resource-based palliative care guidelines based on the socioeconomic condition of the regions. It should be there, and strict implementation of these guidelines with under supervision. And government also should undertake a thorough review for the inclusion of palliative care at all the levels. Healthcare professionals also should get training for providing palliative care, and even the monitoring and reporting of availability, accessibility, and opioid consumption at the regular intervals, it should be taken care. So the palliative care needs to be provided in accordance with the principles of universal health coverage, and all the people, irrespective of their income, disease type, or age, they should have access to palliative care. Financial and social protection systems need to take into account the human rights to palliative care for poor population groups also. So the specialist palliative care is one component of palliative care service delivery, and but a sustainable, quality, and accessible palliative care system needs to be integrated. It should be integrated in the primary health care, community, and even in the home-based care also. And as well as it is supporting care provided by the family and community. Volunteers also can take part in that. And for providing palliative care, it should be considered as ethical duty for all the healthcare professionals. So here I would like to convey my best wishes to the organizers for conducting this virtual conference on palliative care and update. It is a sensitization program for nursing fraternity and organized by Sri Vinoba Bhave College of Nursing, Silvassa, in association with Nursing Scholar Society and DNIP Care. And I hope that it will be really very fruitful and informative for all the delegates, those who are participating in this sensitization program. And thank you so much for giving me this wonderful opportunity to be with you and to interact with you all. All the best for today's virtual conference. Thank you. Thanks a lot.
Thank you, ma'am.
Thank you, ma'am, for such a wonderful inaugural speech. It's my honor to welcome Madam Professor Dr. Bimla Kapoor, a special guest of our today's program. I would like to give glimpse of Madam credentials. Madam have done her BSc in the year 1970 and Master in Sociology in the year 1975, MSc Nursing with the gold medal from RAK in the year 1980, and MPhil from again RAK in the year 1990. And Madam also did postgraduate diploma in distance educations in the year 1998 and PhD on development of evaluation model for nursing programmed through distance education in the year 2005 from Indira Gandhi National Open University. Madam also have done a lot of short-term courses. Very few are course in research methodology, which was organized by National Institute of Health and Family Welfare, Government of India in the year 1982. And course on health assessment by RAK College of Nursing. And lot of credentials for Madam. We were trying to concise, but let me try my level best to explain about that. Madam is elected first president of Delhi Nursing Council, and she established the Delhi Nursing Council with bylaws. And she was the first nurse who have established distance education through IGNOU. She laid down the syllabus for post-basic nursing. She was the first director of Health Science National Open University in New Delhi. And she initiated establishment of colleges of nursing based on the personnel needs. And she was the first person who introduced the registration and the re-registrations of the Delhi nurses for the quality improvement in the nursing fraternity. There are many more honors and awards, very few I would like to just quote here. In the year 1981, she was awarded a President Gold Medal for Master in Nursing program by Delhi University. In the year 1982, she was awarded T.K. Andrenwala Prize for Research in Master of Nursing. And 81, awarded by Nehru Foundation for Excellence in Master of Nursing. And 1993, awarded WHO Fellowship as a county representative. And 1998, she was awarded with the NHS 50th Anniversary Fellowship by the British Council at UK. And 2000, the year 2000, she was inducted as a member of the Sigma Theta Tau International Honor Society of Nursing. And in the year 2010, she was awarded by Trained Nurses Association Award for contribution in nursing education and research. Madam was the first author of psychiatric nursing textbook done by Madam, and there are a lot of published research work. And the person who was introduced to the role of in-service and pre-service nurses on the prevention, care, and cure of HIV and AIDS. And she have contributed a lot of nursing education quality improvement in terms of like curriculum development for post-basic BSc nursing in the IGNO, and she have contributed a lot of chapters again from the IGNO for the various courses. And the global commitments which was done by Madam is in WHO Thailand, country representative from nursing to develop protocols on rational use of drugs and the health system in the country. And Sukhothai Open University, Thailand. Again, she has presented various papers, and All Asian Open University Conference in Hong Kong for the globalization of nursing education. Madam, we are extremely honored to have you here. Even our age is not even equal to your year of experience. We are very proud to be having you here, Madam. Thank you so much. I request you to give the speech for the audience of today's program. Over to you, Madam.
Thank you so much, dear. Good morning, everybody. And I wish I had told you you could cut short there so that we could have more of the discussion. But it is also a pleasure to listen the way you were speaking and the love which was pouring when you were talking about, your senior colleague. Well, let me not spend much time because we are already late because of the technical glitch which we had. But I think quite of my part has been taken over by Achala, and she has introduced very many things when the policy for the palliative care is concerned, but I'll do a bit of my share. Well, let me just begin with it by saying that our president, Dr. Binu, who is a national president of NSS and Alka Secretary NSS, in collaboration with the Dr. Nirul Principal, Vinoba Bhave College of Nursing, and very, very capable faculty, and MSc Nursing student of Silvassa, Dadar and Haveli, and of course, our chief guest of the day, Ms. Achala, ADGNS. It's proud to see her. Mr. Hamza, Mr. Suresh, who are the part of the organizing team. Of course, we have all the nursing faculty of Vinoba Bhave College of Nursing, eminent panelists whose names I read and I was feeling very happy. Well, I always feel, very proud to get associated with anything to do with the palliative care because sometimes I feel that these conferences and these discussions help me to share also and learn quite a lot from the panelists, from the speakers, from the chief guest, and my knowledge really improves on palliative care. Every time when Hamza and Suresh tell me to join, I really learn and come back. From the audiences, I learn quite a lot. From the parents, I learn. And today was the day when he said that it is for the sensitization of nursing fraternity. I was very proud to hear that, because we know that people suffer. I think Dr. Achala has mentioned very clearly that palliative care is not only listed or demarked to the people suffering from cancer, but other patients also, other type of patients also, diseased patient. But most of the efforts are being made by for the cancer, the reason being that the treatment is very, very expensive for the cancer, for chemotherapy, for radiotherapy, for other kind of drugs. It's so very expensive that yesterday night I was talking to somebody who went through all the chemotherapy, radiotherapy, and bone marrow transplantation, that how expensive it is. And he said that because I was being covered by the government, I could manage. Otherwise, it was not possible. So having learned this, I feel, that is the reason the palliative care is being given more attention and more importance. So I think, because we know most of the population, when they are not able to manage those, they think that let us have a peaceful treatment and care, and then see what the life is to us. So the importance stage where the curative treatment is not possible and is not able to save the life of the patient, I think the palliative care comes into picture. I quite agree that when Dr. Achala said that we should start as early as possible, but it also depends upon the preparedness of a person, preparedness of a family, and also the facilities available, which are not many facilities in our country so far. So having felt that disparity, WHO in 2014 emphasized that palliative care must be integrated into the healthcare setting. Then only we will be able to get the right kind of care, right kind of people to see that they are given care. This should be in the community and also patients' home, and that it must be the responsibility of all healthcare providers. Now, palliative care does not include or involve expensive therapies and sophisticated technology. Instead, it is human, realistic, and cost-effective approach to treat symptoms and to improve the quality of life of the clients, and also satisfying the families. Now, I think, as Achala has mentioned, that palliative care may not be only listed as a cancer, but oncology, but other aspects also. Let me not go into that. For me, the nursing personnel are equipped professionally to prevent or treat as early as possible the symptoms of the disease and side effects which are due to the medications or treatment, and also psychological, social, and spiritual problems related to a disease and its treatment. They are able to handle very well. They are qualified. This, as Achala has said, no, the beginning, I think the comparer said that it is also called as comfort care. So imagine for palliative care, we're talking of comfort care, that how much maximum comfort we can give, and palliative care and supportive care we can give to these clients or these patients. Dear nurses, with your knowledge, develop efficient procedural skills and an attitude of caring the patient in hospices or at home on palliative care is very much required, because I don't say that you do not know. You know the skills, but there may be an extra touch. It is understanding the symptoms, managing the patients, and providing passionate and empathetic care with good listening abilities. I mean, that definitely provides some comfort to the patient and families. And that's what is needed more in the palliative care. Just holding hand of the patient when the patient is crying. You don't have to speak anything. Just hold the hand of the person. Be empathetic, not sympathetic. Listen to the relatives. This is going to give lot of peace to the patient and to the relatives, that here is someone, who is able to, listen to me without even speaking, without even expressing my word. The nurse is able to understand. And that empathetic ability, I think from the first year onwards, the communication skills, the interpersonal skills, the empathetic abilities, all that is a part of you. But somewhere, because of the overload of work, Because of lack of nurses in the clinical area, we are not able to exercise those learned attitude or those learned behaviors because of the overloading of work. But in palliative care, this is what is going to be required, along with your technical knowledge, along with your therapeutic intervention. But these comfort measures, these interpersonal relationships, these effective communication skills, good listening are going to be very, very important. And that is going to really satisfy the relatives also. You also will have a lot of satisfaction at the end of the day when you go back home. No, the principles of palliative care are many, and I don't think we need to really go into it, but we want to affirm life and regards dying as a natural process through the palliative care, neither hasten the process nor postpone the death. Very painful, but hastening is not done because let it take its own process, and postponing is not done by artificial means, and that's what is a palliative care. Sometimes it is painful and you think miracle may happen, but providing relief from pain and other distressing symptoms is very important. Integrating the psychological and spiritual aspect is significant in this case, as per the need of the patient, as per the beliefs of the patient, as per the thoughts of the patient. That is to be taken care of. Offer a support system to help patient live as actively as possible. I remember a case reading somewhere where a patient who would give care to everybody from morning till evening, and will get tired at night and sleep, until one day he himself slept off peacefully. The people came to know that he was not a caregiver, but he was the patient himself, who was staying there, but nobody came to know because he was such a care provider. Look at the empathetic ability, need-based care, managing pain, treating constipation, handling difficulty in breathing, as was being mentioned by Achula, managing anorexia is very important, and tiredness, depression is one of the things where they may feel that how do I care my family members because I'll be going away. So providing love, talking to the patient, also using complementary therapies, massaging, a warm bath, any complementary therapy which helps the patient to get relaxed are very important. So I think these patients are very prone to infection. As nurses, we have to really use those techniques or mechanisms by which we can prevent the cross infection and infection. I think you are very well aware of it. I don't need to dwell, and the panelists will talk about it. Common symptoms at the end of life, also may cause delirium. And we need to handle the delirium in a very different way than the person suffering from unconsciousness, because this person is conscious, the family is there. So you will have to manage the delirium in a very pacified manner. Educate patient, educate families and carers. They can also have access to local treatment, to local psychological therapy, to local social therapies, to local religious or spiritual therapies. We need to orient. We need to be really humane with these people, not other. I'm not saying not with other patients, everybody, but because these patients, they know why they have come into the palliative care units and they are aware of it. So we need to really help them to live every day very actively. So relieving these symptoms are the key aim of palliative care for us as nursing professional. So integrated framework as talked about, management of pain and physical symptoms, holistic care, caring, compassionate, and skilled providers should be available in the clinical area, in the palliative care homes, timely and responsive care, patient and family preparedness are the essence of this palliative care. With these few words, let me thank for giving me this opportunity to share with you that you are the nursing experts and provide this care day in and day out, no doubt about it. But an extra empathy, as an extra step forward, as an extra time sharing, as an extra time to hand holding of the patients and the relative, their desires will definitely, these people will definitely get peace of mind towards their last days during the palliative care, and the relatives will also be at peace. But remember, you will have satisfaction and you will sleep very comfortably at home that you provided the care to a person who actually is needing the care at the last phase of his or her life. Well, with these few words, I would like to thank the organizers, the Vinoba Bhave College of Nursing faculty and the students, MSc nursing students and all other dear students for inviting me to share my nursing concerns, which I'm very passionate about with you all. So with this, I would like to wish best of luck for the following session, to the panelists for sharing their experiences, and to all the organizers for having a success and seeing the success of this particular day. Thank you very much. Thanks a lot.
Thank you, madam, for enlightening us with your speech. We certainly will inculcate all your words in our nursing care, ma'am. Thank you so much once again. I'm delighted to have Madam Professor Dr. Alka, Principal, Vibrant College of Nursing, Surat, as a guest of honor. I just would like to glimpse about Madam Alka. Madam is PhD in from Malvanchal University, and Madam held various positions, the clinical as well as in the academic side. And she is the Secretary of Nursing Scholars Society and founder and secretary of Nursing Scholars Society, and she has been contributed as an editor in various journals, which is indexed at the national and international level. Madam also a member in various nursing associations, example, TNI, Clinical Nursing Research Society, Nursing Honor Society of India, and she has done a lot of certificate courses. Very few are like a capacity building program of midwifery faculty organized by Indian Nursing Council, and certificate course of heart failure for nurses, etc. And she has done a lot of publications in the national and international journals, more than 15 articles she is having. And she has published the textbook on applied anatomy, and she has been a resource person in various national and international conferences and the seminar. And she has been a moderator for various webinars also. She has organized a lot of conferences, seminars, and workshops. And she has been awarded as Best Staff Nurse in the year 1998 at ACPM Medical College, and Best Teacher Award in the year 2005 at ACPM Medical College, Dhule, and Best Professor Award by UIJIR in the year 2021. And she has been selected as a Research Excellence Award by UIJIR. Madam, we are delighted to have you in our conference, madam. Thank you so much for being with us. Over to you, madam. I request you to deliver a speech to the participants. Thank you.
Thank you, ma'am. Thank you so much. Good morning, everyone. Good morning, Vimla Kapoor, ma'am. Good morning, Hamza sir. And good morning to all the faculties. Of course, good morning to Principal Vimla Niru, ma'am. Sorry. So it is my honor and privilege to talk in front of you. First of all, I congratulate to Sri Vinoba Bhave College of Nursing to organize this type of webinar. And of course, DNIT Care is doing very good campaign in national wide, and it's a good moving for all the nursing fraternity. I'm very happy to share this because Vibrant Nursing College also organized in the month of March Palliative Care Nursing Conference, and the same time I contacted to Tamega University, and they also organized a conference in the month of April. So for this, I thank you, Mr. Suresh Tipi sir. Always he is communicating to all the nursing faculty in the various colleges in national wide, and he's doing a campaign. So thank you to all the team members of Palliative Care Nursing Care, and it's very beneficial for every nurses fraternity. Last time there was a conference, and Sister Hani was a speaker, and what she told, and in her session, I was thinking like it's very sensitive, and what Bimla Kapoor madam said, we should be sensitive. We have to do a care, or we have to give a empathy, not a sympathy to the patient. Actually, we have a lots of skill, we have a lots of knowledge also, but that knowledge we have to use in our patient. And first, the nurse should be sensitive, and then only she will give a care, or she will do a care with a patient. So I think during her session, I was remembering those days when I used to as a staff nurse, and we have given a care. And now also when we are teaching in our college, and when we are conducting lectures, so with the sensitivity, we are telling to our student also, be a sensitive and do a care to your patient. See, holding the hand of a patient, which is give a lots of satisfaction to the patient, and the patient will think like psychologically, the patient half of the disease will go. So these things we are telling to our students, and the students are doing also. But sometimes maybe the care which is when the nursing care, or we can say the education, every department, not only nursing, it is changed, and it is the sensitivity somewhere it is lack, or we can say sensitivity it is there. But I think I don't know what to say, but it's changed. But being a nurse, we have to give a care with the sensitivity to a patient. So our Nursing Scholar Society is always supporting this type of event. We are organizing so many conferences, so many workshops, and now also our Lavender chapter, Delhi chapter, is organizing one of the workshop. It will be in the month of February, which is a physical conference, and which is organized by Dr. Mirza Sood ma'am, and of course Bimla Kapoor ma'am is there. So we are supporting to A&M and PhD nurses. We are appreciating to them. So I think Nursing Scholar Society always be with us, and those who wanted to join Nursing Scholar Society, they are welcome in a Nursing Scholar Society. And I'm very happy to share this. We are completing 2 years in this month only, 28 December 2021. We were started Nursing Scholar Society, and till now we have opened. I think 19 chapter we have opened, and some more chapters will be open. Every month we are having one induction ceremony at the end of month. So I thank you to Mr. Suresh Tipi sir. He is always supporting to all the nursing fraternity and organizing this type of conferences. And secondly, I thank to Dr. KP Hamza sir. Last time he was also speaker, and he was enlightened us, all the team members in DNIP care, who are providing a great knowledge to us. I congratulate Professor Binu sir, Dr. Binu sir, who is supporting us always, and thank you me to giving this opportunity. Thank you so much, ma'am. Thank you so much, ma'am. Over to you.
Thank you, madam. Thank you so much for your speech, ma'am.
Thank you, ma'am, for your inauguration address.
I am extremely happy to announce that we have crossed 2,000 registration. I welcome all the participants. I kindly request participants that pre-test can be shared in your given email ID and WhatsApp group. So please complete your task and pre-test response. Now it's time for us to main into the scientific session. We have amongst us Mr. K.V. Hamza, General Secretary, DNIP Care.
Sir is a retired senior accounts officer, Ministry of Finance, Government of India. He has graduated from Kerala. Sir is working as a palliative care volunteer and a General Secretary, DNIP Care. Sir is a registered volunteer group for palliative care since 2008. Sir is working as a volunteer who took sessions on a palliative care in many places, including University of California, Riverside, USA. Sir has received KMCC Social Service Award. I am extremely happy to have you, sir, here. Sir will be summarizing our topic and moderating our question and answer session. Thank you, sir, for your presence.
A very good morning to everybody. Thank you very much for the introduction. And today, on this 17th December, we are all here, Professor Dr. Bimla Kapoor ma'am, Rakesh sir, Stella ma'am, and Ajla ma'am, ADG Nursing, then Alka Tajna ma'am. Everybody is and this is the palliative family, we say. So this this is a real good opportunity that along with Sri Vinoba Bhave College of Nursing, Silvassa, we are having the Nursing Scholar Society also. Just I heard that it is Nursing Scholar Society is set up last 2 years back only, and having about 19 chapters. That's a very good achievement, ma'am, all of you. So, and this is a real approach. See, yesterday there was one parliament question to the Minister of Health, and the answer to that question was that there are about 35.14 lakh nursing professionals in India, and that comes at 2.06 nurses per 1,000 population. So from that, we can understand how much is the requirement of the nurses. The nurses, as I always say, nurses are there when the first breath is taken, and nurses are there when the last breath is taken. So if that much requirement is there, then this 35.14 lakh for the entire 140 crores of Indians, it is not enough. So the requirement is that more and more people should come to this profession with that commitment, and to give the smile if they see a patient without a smile. So that is that extra step that Bimla Kapoor ma'am was telling, the palliative care. So palliative care is not a rocket science. Of course, next is first speaker for the session is Alice Stella Virginia ma'am. She will definitely say that it is not a rocket science, and she speaks of that. So with when we talk about this, is that it is not a rocket science, but at the same time, it should start from that very original things. Just like in Delhi, we are having our metros or our buses, trains, everything just like the same way. So I used to say that if you see a guy or a person you are just seeing with a bald head and a big packet of MRI or CT or anything, and standing in the crowded public transport, and while we are comfortably sitting on a seat in that maybe metro train with air conditioned metro coach, and he is there struggling, that means at least just raise your bum and offer that seat, and you start the palliative care there onwards. So that 15 minutes comfort you are leaving for giving comfort to that person, suffering person. So that is the minimal thing of palliative care one can understand and start with. So I'm not getting into that so much, because I am not at all a medical professional. So the medical professionals are there. So let us welcome Alice Stella Virginia ma'am to deliver her thoughts to all the nursing fraternity present here. Alice Stella ma'am, please, floor is yours.
So a very good morning to all. And I'm sorry, I'm just I've had to leave from here by 11:45. So that's why I just pinged in first. Okay. I'm very thankful to this one, Hamsaka, because he's the one, and the Suresh. Anyway, he will be there somewhere around. Okay. So thank you both, because they are the persons who always keep on inviting me. And also thank to the this nursing group who has invited me for this session. So I'm not going into deep. My session is all about communication. Okay. Since morning, we all were hearing from each and every one communication about palliative care. Palliative care, Dr. Rakesh will more palliative care, what it is exactly. But for me, when we talk about palliative care, all the nurses should remember one thing. A patient and a family is going through many difficulties and sufferings. In that time, you need to be there next to the patient. You should have empathy for patient, and moreover, you should be compassion. You should have compassion for patients and their families. Never leave the family on one side and just look onto the patient. And now, when you look at a patient, please look him as a person, not as a disease. That is the first thing you have to keep in mind. They are not a disease. They are a human being just like us. Okay. And when we start communicating, what we are going to communicate with the patient, because as you all know, communication is just sharing the information with the patient and family. And sharing in the sense, the patient and the family are going to share their problems with us. That should be the first priority. It's not what you're going to share with the patient and the family. Give time for them to talk because they are sharing their problems. I just have one question to you all. How you communicate to a patient? In which all way you can communicate to a patient? Can I have one or two response? In which way you can communicate to a patient and a family? Anything? How do you communicate with a patient?
Both verbal and non-verbal.
Non-verbal, yeah. Professor Dr. P, she has told, very right, verbal and non-verbal. And which we use more?
Non-verbal.
Non-verbal, very good. So that's very right. Thank you so much. So remember one thing, we use more than 70% of our communication is non-verbal. We think we talk a lot, but we don't realize that many of our non-verbal communication goes to the patient first. And that is why whenever a patient is asking whether I will die, whether I'm suffering from cancer or anything, our expression changes. Even if you from the mouth you tell, no, nothing to worry, everything will be fine. No. Our expression is already, our silence has already given the patient the answer that you are suffering. Okay. So that is one thing. There are a lot of things. If we have a session for more than 1.5 to 3 hours, we can have a lot of talks about these things. Okay. And the second thing is, remember, it is not simple to talk to a patient or a family. Never think communication is simple. It's very, very complex. Why is it complex? Because anytime when we talk to a patient, we think whatever is there in mind, we are talking, and the patient, no. Many things goes inside the patient's mind. He'll be just thinking whether I should say this, whether I should say that. If at all I tell these problems, what they will think of, especially if it is out of physical. When we talk more about the psychosocial problems, spiritual problems, financial problems the patient is having, the patient do think inside, can I speak to them this? And if I say, I'm not able to sleep in the night, I'm worrying too much, maybe they will think I am a psychiatric. So we need to explore the patients, not only the physical, but the psychosocial and their spiritual, and of course, a little bit of their financial also we need to cover, so that we'll come to know what they are going through. Many of the time, the patients do have a lot of physical problems because we are not addressing their psychosocial, financial, or spiritual problems. And that is why they have a lot of physical problems. I usually give a very good example because I was trained in army. I remember when we get the dependents, especially in these winter seasons, with the dyspnea, bronchial asthma patients, if we say to the patient, tomorrow you are discharged, by early morning we can hear the sound of the wheezing. When you go, the patient will be wheezing. So very morning when the doctor comes, we have to say whole night he was wheezing, we have to give the medications. And sir will say, okay, discharge cancel, let him be there for 1 or 2 days. Immediately when the doctor leaves the ward, I can see the patient sitting and laughing, talking, moving about. And once it happened also, I just went and asked about that. And you know what he said? He said, if I am at home, nobody cares for me. Nobody asks me anything. But you see here, all are coming to meet me. And especially you people are taking a good care of me. So what is that? It is just a psychological problem, a psychosocial problem where he wants it, the attention towards him. He wants the people to take care of him. Okay. So when we talk about all these things, there are 3 things that you have to keep in your mind always. Like all the other speakers, they were saying, empathy is one thing that you have to keep. Please don't have sympathy for the patients. Nobody likes. Even if you are in that position also, they will never like that empathy. Now, the second thing is when you talk to your patient, remember the patient wants truthfulness talk. The reality they want, that is, we say genuineness. Talk to the patient what is happening. Of course, please keep in mind how to break bad news, how to talk to a patient or a family with colluding. That is a very, very different matter. Just because I said, please don't go and tell the patient tomorrow that you are suffering from cancer or you are dying. Please don't do that. What I mean to say is, truthfulness is very important when you talk to a patient. Because if suppose you lie to the patient and the patient will come to know tomorrow he is not well or he's suffering from something like that, he will never believe you. That is very. And the third thing is positive regard to the patient and the family. It's very important to have a positive regard to the patient and family. Why? No discrimination should be there, caste, creed, whatever it is. Recently, I'm in Tirupati. We were giving a 10 days program to the doctors and nurses over here. Okay, that's a physical only. We had been to the patients, we went to the wards, we went to their home visits, and a lot of patients we saw. And one patient, he just said, nobody is talking to me. My family is ever away from the, even when the patient goes to some places, people avoid him. And just why? First and foremost, he's having a kidney failure. Second thing, he's retropositive. He is having more than 10 brothers and sisters who is not taking care of him. His wife is also positive. And what he said was, he said, I had looked after him all through this life. I have been supporting them. But when it came for me, nobody is there. And there is a stigma. That should be a positive regard. Whether the patient is a terrorist, whether the patient is a retropositive patient, for that matter, let it be anyone, X, Y, Z, black or white. You have to treat the patient because he is a person who has come to you with his problems. And just look into that in that way. Give a positive regard to the patient, what we say in more unconditional love. You have to have a love for a person. There should be unconditional love. These are the 3 main things that you should keep in mind. Empathy, why? You're putting yourself in their seat, putting your shoes in somebody else, putting your feet on somebody else's shoes. I mean, see, I don't think that you will feel or you can understand or something like that. Okay, feeling is something everyone cannot feel what the other person is feeling. But still, when a patient is talking about his psychological problem, about his family, you need to understand why he is talking about this. Because apart from the physical, a lot of things is going around him. He wanted to address that is suffering more psychologically, socially, and spiritually. And that we need to address as nurses. And if the nurses are having a very good attitude, your approach also will be good to the patient and the family. And we say, what enhances the communication? Your touch, if it is appreciated. The eye-to-eye contact, the face-to-face sitting with near the patient, that pleasant face that you have, not that constipated face. A little bit of smile on your face when you approach the patient. Your tone, the way you greet the patient and the family, your gestures, everything counts when you communicate with the patient and family. Give equal importance to the patient and the family. And now when we again talk about communication, of course, we come across a lot of problems when we communicate with the patients, especially because they may be illiterate, they cannot understand our language, because we use a lot of medical terms. Many questions they keep on asking, for which sometimes we think, why we need to talk to all these things to this patient? Let them take the treatment and go. And sometimes we are very busy. I can admit that when, especially in colleges, government colleges, we have a lot of patients, very busy crowd we do have. But how many patients really need our time? Countable patients only need our time. So we need to sit with the patient and their family, spend little time. And if you don't have time, tell the patient, I'll do one thing. After I finish my work, I can spend little time with you, because I need to attend all the patients also. And the best thing is, as soon as you enter in your ward, in your shift, just make a quick round around. Just a smile on your face, hi to everyone, come back to your station and start on your work. And while just giving even injection, you can communicate to the patient. I always say, when you're doing small procedures, you're doing a wound care, you can just communicate with him so that he'll be distracted also. That's another thing. Answer to their questions. And if you don't know the answer, tell them, I don't know about this. I can find it for you, or I will make someone to come and talk to you. Don't leave the patient when the patient is talking about a psychological problem because you cannot tackle. No. If you are not able to, just tell him, I will make someone to talk to you about this because she's better than me. She'll be able to address your problems. Okay. Now, again, when we talk about our professionals and the patient side, the difficulties we feel, now the main problem is language. Because some patients come from other states, they don't know our language. So try to find out someone who can talk to the patient in their own language, in their slang. Another thing, please don't use medical terms. As far as possible, try to talk in the patient's language, come down to the patient's platform and explain to them. Maybe you can draw maybe one of our organs where the patient is suffering, you can show them this way, or talk to them instead of telling bronchoscopy, endoscopy, tell them you're going to put a tube. Why the tube is being put? When you come across a patient, since long, the person is a stroke patient, maybe we will send from the hospital saying that now you can take care of the patient back home. Come show them how to make an occupied bed, how to take care of the catheter, how to give a ice tube, this one, feeding. I'm not telling about only lecturing. Practical thing you have to show them, so that even a wound care, pressure ulcer, anything, once they go back home, they will be able to do it. These are the difficulties the patients are facing and they wanted to communicate to you. So empower the patient and the family for that. And there are a lot of fear inside the patient to address their fear. Spend some time with them and see that we address these things in their own language. And anytime you need to talk to them in private, find a quiet place for them. That is very important. Just 1 minute. Yeah, just 10 minutes. Why, what happened?
Just I want to say bye-bye.
Okay. Okay, but this is an online session. Huh? Thank you so much for coming. Okay, bye. So here what happens is, whenever you spend a little time with the patient and the family, they just open up to you because they know that you are listening to me. God has given us 2 ears and 1 mouth. And you know, usually what happens? We forget about that. We think we have 2 mouths and 1 ear. No. Listen actively to the patient, what the patient verbally and non-verbally. Both the ways the patient is going to talk to you. Many things comes verbally and most of the things are non-verbal means. If you look into their eyes, you will come to know what they are really facing or going through. And that is very important for them also. So the need of communication is very, very important. Why? Relief of anxiety will reduce their physical problems. Isolation will be reduced because you are empowering the family also. You're communicating with the family also. You're communicating with the family that the patient is suffering and is going through these difficulties. He needs the family's support. And another thing, when you communicate with the patient, remember one thing. When we say like face-to-face or eye-to-eye contact, it's not just looking at the patient's eyes. Maybe the patient won't look at you also, but head to foot, observe the patient. I have come across many patients, they will never say they are having edema in the feet, but I can see there is edema in the feet. So observing the patient from head to foot is very important. By just sitting and talking itself, you can observe the patient. Many things you can ask the patient. So empowerment is very important to the patient and the family. Then, when we talk in their own language, they understand more. So the need of communication is that don't use medical jargons or medical terms. And if you communicate properly with the patient and the family, there will be better complaints with whatever we do for the patient, with the management. Otherwise, every now and then the patient will be a difficult patient for you. There will be a lot of conflicts because they won't adjust with the disease process because nothing has been explained to the patient what is happening to him. We are just going giving injection, we are just going giving medications. Everybody's walking up and down. People coming for the rounds, doctors, nurses, everything, talking over the phone, over the patient. And patient is in the center. This side, that all are standing and they're talking to each other. And patient is also looking what is happening. He cannot understand. And he sees the face, the expressions of the patient, doctors and the nurses, and he feels that something is wrong with me. That's why they're talking very seriously. I always say, please don't talk over the patient. If you need to really discuss something very important, very serious, please go a little bit that side and talk, have a discussion. The patient will become afraid. You'll get frightened. These are the things that you have to remember. And of course, as I said before, please have a nice, pleasant face. I don't tell that you have to go to the patient and say, haha, how are you? And look, nothing like that. Okay. That pleasant face should be there. Leave all your problems at home. And when you go home, leave all the problems in the hospital and then go. So when we talk about this one, one more thing what I remember is during communication, our tone also should be good. Like if I suppose say, okay, Shweta, please give me your book. That is one tone. Same, I can say, Shweta, give me this book. See, my tone has changed and the patients can understand our tone. You all must have come across when we regulate the IV fluid and do your work very peacefully, and suddenly you say, see that the IV fluid has finished. The expression and the tone changes. We'll just look at him and say, that's enough. The patient understands. And when you take the history, don't just ask the patient whatever you want. No. Maybe his history has started somewhere 40 years back. He may be correlating with his disease now. Just listen to the patient, his present, his past, his school history, everything. Just listen to the patient, and whatever you want, just take it out and put it in the paper. And I tell you, when you go near the patient, please, for heaven's sake, don't carry whatever you have to write. Patient will be talking and you will be busy writing. That's a distraction because you are not listening properly. When you talk to your patient, no distraction at all. Just listen to the patient. After that, go and sit and put up whatever you have heard from the patient. If you have any doubt, you can just go and tell, I forgot one thing you told me. So-and-so there was some problem. Can you just explain to me once more? Then you can put it up. And summarizing whatever you have heard what the patient and the family has told you, simply summarize it. That time you will come to know what you have left. Just summarize. You have told me these are the problems: physical problems, psychosocial problems, spiritual problem, financial problem. Did I leave something? So they will add on to it. This is also communication. And again, let us have one more look. So there are a lot of barriers for communication. First and foremost is nowadays is the mobile. Patient's mobile, family's mobile, and our mobile also, okay? Because nowadays, when I'm working in a medical college, I know it very well, not only medical college, I used to go to the private colleges also. I've seen all the nurses, all the doctors, each and every healthcare provider in a hospital has a mobile. All are very busy with the mobiles only. I sometimes feel it should be told very strictly that not to use mobile unless it's very emergency in the wards, in ICUs and all. Because maybe sometimes a patient comes and asks you something, you're very busy talking to your family or to your friends. I don't say no. In emergency cases, you can use. I know very well about my own family. They never call me from 7 to 2 o'clock. Only if it's an emergency, I will get a call. Otherwise, they know not to call me. So I know it will be an emergency. Even my staff, my doctors who are working, they will never call me out of the time. Because I have told them very clearly, anything emergency, you just call me. And if I feel it is really emergency, I will tell the patient, just wait a minute, I want to just attend this phone. Or if it is not so, you can tell them, please call me after some days, otherwise I will call you, I'm talking to a patient. I have a discussion over here. Okay. So that is very important. But the other barriers, so many barriers are there. Looking in the clock, you're talking to a patient and your eyes are on the clock saying that I don't have time. Never talk to a patient in the corridor or when you are getting into your car. That's also a barrier. Want to talk to the patient, sit near to the patient, give a good posture and listen to the patient. You're listening to the patient. That's good. And other barriers. Don't take everything like when the patient says. When humor is good, I don't say. If the patient is also taking in that way, some of us are going, everything will be all right, don't worry. How can it be? I am worrying because I'm not well. So don't tell the patient, don't worry. It doesn't make any change, okay? Don't worry, that word is it's all right, I feel it's not good. Okay, and if the patient starts crying, leave them to cry. For some time, let them cry. Tolerate silence. If the patient becomes silent, leave them for some time. After that, you can ask whether we will continue or whether we'll stop. Maybe the patient has become very emotional and not able to talk to you. And of course, don't talk philosophy and all to the patient. Patient cannot understand philosophy and all. And main thing is, please don't compare the patients with other patients. Comparison is not good. Patient can compare and tell, oh, I saw that patient, the other one who came in the night, he's suffering a very long, I'm fine with that. But if you compare, you're pointing out, look at that patient is fine. He's having more problem than you. You're having a very small problem. No, we say pain is what the patient says hurts. If I say I had a small cut over here and it pains, it means it is paining because I cannot tolerate it. So try to understand that what the patient is communicating to you. Listen to them. Because palliative care is a total care, not only physical, psychosocial, and spiritual. Of course, we try to understand their financial problems also. Okay, so in a nutshell, what I have to say is communication, verbal and non-verbal, it is very complex. And of course, always listen to the patient. Don't ask them any close questions we can ask, but open questions are better. Like we can ask the patient, how are you today? What brings you here? Don't ask leading questions and judgmental questions. Judgmental question is just what I told you is unconditional love we need. If you ask tell a patient, because you have been smoking, that is why you are having lung cancer, and that's all finished. So no judgmental questions to the patients, or no such talk should be there. Open questions. Close questions you are asking, try to open it more. And you should have your own style of communication. Learn from your seniors, learn from your juniors, learn from everyone and take out the best thing out of that, and you can communicate. Okay, so I thank you all so much. I think they have already come to pick me up from here. Okay, so within this, I think hardly I've taken about 20-25 minutes only. I hope you people understood what I have trying to convey to you all. And once again, Hamsaka, and thank you, and thanks to this institution also, and bye.
Thank you, madam, for your support and valuable information and giving us time from your busy schedule. Ma'am has over 36 years of experience in nursing. Ma'am trained from military hospitals, Secunderabad and Jhansi, and being commissioned as a lieutenant colonel in 1986. Madam also served in Ministry of Health Libya and the Ministry of Health Sultanate of Oman. Ma'am continuing her services by online training for doctors, nurses, and nursing students in collaboration with Indian Association of Palliative Care, Pallium India, CIPLA Training Center, Line Collaborative for Palliative Care, and others. Once again, thank you, ma'am. Moving forward, we have amongst us as a dynamic personality, as a resource person, Dr. Rakesh Garg, additional professional, Institute Rotary Cancer Hospital. I kindly request Ms. Neha Mishra to introduce our first speaker. Thank you, Ms. Sethi. It is a great pleasure for me to introduce
Please unmute yourself, Pooja.
Dr. Rakesh Garg sir is an additional professor working in Institute Rotary Cancer Hospital, AIMS in Delhi. Sir presently work as an
host mute as Hello.
Not being heard, please.
Sir, sorry sir for the interruption. Sir, present position and institution. Sir is an additional professor, anesthesiology, working in critical care, pain and palliative medicine in All India Institute of Medical Sciences, New Delhi, India. Sir, education was, sir completed MBBS from University College of Medical Science. Sir completed his MD in anesthesiology from Maulana Azad Medical College, and sir is working as a senior resident in All Indian Institute of Medical Sciences, New Delhi. Sir has published more than 250 publication articles at international and national journals. Sir has authored 25 chapters in book, and sir is also editor of 2 books. Sir is life member of more than 20 national and international professional bodies. Sir is an editorial board member of 12 international and national journals. Sir reviewed over 100 manuscripts for international and national journals. Sir is also trainer and instructor for ISA, IRC, CPR, PCLS, ACLS, BLS, ACLS, AUTLS, PHTLS, IAPC, CCEPC, and ACCC. Sir is worked as a vice president in All India Difficult Airway Association from 2019 to 2021. Sir has also been the core member for the formulation of various guidelines, courses, and programs. Sir has conducted over 50 airway workshops, mechanical ventilator workshop, CPR workshop, research methodology, vascular access workshop, pain management, palliative care, and many more. Sir has delivered 150 guest lectures at various conferences and workshops. Sir has presented over 90 presentations at conferences in oral and in poster form. Some achievement and rewards. Sir is awarded and felicitated by Ministry of Health and Family Welfare, Government of India, and as well as various apex body at the national and international level. Some of them are, Sir got second prize for Singapore Medical Journal Best Research Paper Award in the year of 2011. Sir got the ISA President Award in the year of 2015, the 2015 Leader Award. Sir had also got Singapore Medical Journal Reviewer Recognition Award in the year 2017. Sir got Publons Peer Review Award in the year of 2017. Sir get the award for President's Appreciation Award in 2017. Sir also got award for Academic Excellence Award by Indian Society of Anesthesiologists. Sir had get the award by us ISA Bhopal Award in the year 2018, Albert Nilsson Merkis Lifetime Achievement Award, and also Dr. YG Bhojraj Award in the year 2018 and Outstanding Scientist Award. I will request you, sir, to give your light on this topic. Over to you, sir.
Thank you so much. Thank you so much, Madam, for the kind words. And thank you, Hamzaji, and all the team from the Ministry and Institute for taking this noble awareness program relating to palliative care, which is much needed for the day. I will take you through the various aspects of palliative care. We had a very nice session by Madam Alice Taylor, who has already mentioned some of the important aspects of palliative care. That is quite, I think she has done a wonderful platform presentation, which makes us understand that why do we need palliative care and what are the ingredients of palliative care, which is very, very essential. Now, let me just show you one example, which Madam was also discussing in other context. Say, for example, if you have a 35-year-old gentleman who has advanced cancer pancreas, which is metastatic, and now he presents with history of severe pain abdomen radiating to back.
Sorry
He's
for
unable to lie
interruption,
down.
sir. Please unmute your mic. We are not audible to you, sir.
Am I audible?
Yes, sir, you're audible.
Yes, you are
Right,
audible,
okay.
sir.
So now we will get these type of patients. It will be from an oncology setup, but it may be a non-oncology setting also. Say, for example, patients with end-stage renal failure, end-stage liver failure, end-stage heart failure, and they come with some amount of symptoms which are not amenable to complete care by the conventional management. So at majority of time in our curriculum, in our teaching, in our hospital practice, we'll be talking about the diseased focused care. So we'll be more concentrating on treating the patients for cancer pancreas or a patients for heart failure or a patient for liver failure or renal failure. But what we need to understand is that these patients do require some amount of support system apart from disease focused care. And this is grossly, you can say, a part of palliative care. Because when we say to cure sometimes, to relieve often, and to comfort always, this is the role of each one of us. And if we see in India, almost 3/4 of our patients will come in advanced stages because lack of awareness, because of lack of facilities at certain places. These patients may not be able to identify their cancers at early stage. And by the time they reach a apex center or a center or a cancer center, they will have locally advanced disease or maybe a metastatic disease. And that's why these patients would require symptom relief and comfort measures. Now, this is the conventional definition of palliative care, where we talk of the holistic management of these patients. But what we need to understand is, in the journey of the patient of advanced disease, patient will show a lot of fluctuations that we need to understand, which Madam Alice was also mentioning about, that we need to understand and have to communicate with the patients based on these trajectories. For example, if you talk about the cancer patient, if you see the first graph here, these patients' functional capacity will continue while they are being treated. If they do not respond to the conventional treatment, if the cure is not happening, they will succumb to death, right? And they will slowly, gradually comes down and finally will have end of life. But if you see the other type of diseases, the non-oncology or non-cancer diseases, they will have a lot of fluctuations in between. The example she was giving about the asthma, COPD patients, they will have a lot of fluctuations in between. And that's why each fluctuation, the patient may not be able to come back to the normal baseline value. And hence these patients will gradually deteriorate, but they may not get resolved with the acute events that has happened, for example, say asthma or a heart failure. And finally, they will succumb to death. If you talk about the neurological diseases, they will have slowly, gradually down over many years. And then finally, they will succumb to death, like, for example, dementia or frailty. So this is the lady who started the palliative care movement across the world. And what we are seeing is because of her contribution all over the world. And subsequently, as we are progressing in the palliative care, now palliative care is an interdisciplinary care. And what I mean by interdisciplinary care is you require the inclusion of many people that will provide these patients, these advanced cancer patients, care from various aspects. And the nursing professionals are one of the important aspects which will provide them holistic care by getting it integrated with other peoples, by other specialities, by other disciplines. And hence, that's why the nursing professional is important, because they are in touch with these patients majority of time, and they can make a nice goals of care for these patients with interaction with many of these disciplines, so that the patient gets a holistic care. And that is what is required for these patients, apart from the routine conventional curative aspect that these patients require. Now, who are those patients which we talk about palliative care? Majority of time, we are talking about the advanced cancer patients, but these patients may also be like AIDS patients with major cerebrovascular accidents like stroke or head traumas. These patients may also be neurological disease like Alzheimer's, motor neuron diseases, multiple sclerosis. So these are probably incurable diseases. The patient do not recover to baseline, and they may succumb to a terminal event because they are progressive diseases at times. And that's why all these patients, we talk of advanced cancer, the neurological disease, the renal failure, the heart failure, the liver failure, the respiratory failure, the domain or the need of palliative care is expanding. Any patients with chronic disease and suffering, they would require some amount of supportive care. And this is what the palliative care is. And that's why we have increasing number of population that would require palliative care in India. And the role of nursing professionals becomes very important to take care, because majority of aspects in these patients with advanced diseases, basically the nursing care, and creating a coalition for understanding a good communication and having an interdisciplinary approach. The nursing professionals can take a prominent role so that these symptoms these patients manifest, whether they are talking about the physical symptoms or the social symptoms or the emotional issues or the spiritual issues, they are taken care of by the team members who are involved in the palliative care. Majority of time when the patient is coming to hospital, we usually target the physical symptoms majority of time. Say patient is having pain, patient is having dyspnea, patient is having abdominal distension because of ascitic fluid. But rarely we talk about social, emotional, and spiritual problems. And we have seen in palliative care setting that these problems are also equally important. And unless we target the social, emotional, and spiritual problems, patient will remain in agony, patient will suffer. And that's why we should be a little cautious in taking care of this. Regarding the physical symptoms, there are many, and I think once you do some type of foundation course, you'll be able to contribute towards the symptom management in these patients. These are a couple of symptoms which are commonly seen in our clinical practice, and you can easily understand them and manage them by taking care of these patients for these type of symptoms management. But what also needs to be understood is try to now look for, assess these patients from the other aspects. Now, what we need to do is we need to have something called a person-centered goal of care. Now, this is an important statement because each person is an individual patient. We cannot say that this is the management protocol or this is the plan for all patients. No, each patient is an individual patient, and that's why we have to set goals of care for these patients, looking at a holistic approach from all the aspects that I just mentioned: pain, what I mean, physical symptoms, psychosocial symptoms, spiritual symptom, emotional system. And India being having a joint family, a good support from the family, we should also look from the perspective of the family also. Because many of these, for example, the patient is only the bread earner for the family, and if he or she gets the cancer, he is suffering and having an end of life care, they also will be worried that who will be taking care of this family now, because he is the only bread earner. That's why at times we also need to think of the family, not just the patient. And that's why when we provide palliative care to these patients, we should have basic understanding of the family of the patient as well, or its social network also, so that we can provide him care. And once we start providing all these components, this is what now is termed as total pain management or total management of these patients, or you can say holistic management of these patients. Until and unless we provide the holistic approach, the suffering will continue. Patient will be uncomfortable. Patient will be in agony, and hence we need to look for all those aspects, and you can see that various peoples are involved at each domains, and probably the nursing professionals can take a lead to provide this multidisciplinary team approach to these patients so that the total suffering is taken care of. Now, these approaches in a palliative care setting, when we start providing them, it's nothing that only one specialty will be involved. For example, a patient who is having, say, end-stage renal failure, they will be having the help from not only for nephrologists, they may also require sometimes the chest infection, they may require physiotherapists, they may require nutritional support, they may require nursing care. So this means there will be a lot of running around of the patient at various places. And if somebody can integrate these systems into one, the patient becomes much, much better. Now, if you understand the palliative care concept earlier, if you say a couple of years back, people used to say palliative care is end-of-life care, which is synonymous with end-of-life care, and that is what is hospice care. But no, now we don't say that is end-of-life. End-of-life care is one of the component of the palliative care. Palliative care is providing them comfort care at each step of their treatment, and hence we should be able to provide these type of care to these patients, and hence that's why palliative care has become an integral part of modern medicine. Hospice being one component, or end-of-life care being one component, and hence we need to look for care of our patients. Now, these are the basic principles. I can summarize it. Probably, if you see on this single slide, we can have lectures going over the day, but the final crux of all the lectures of palliative care will be, we need to provide these patients relief from pain and other distressing symptoms. We need to affirm life and regard dying as a normal process. We usually talk about good life, but we need to understand there is something called good death also. If somebody is suffering at the end of life, he is crying into pain, and the family members are in agony, I think it becomes a little trauma for the patient and the family members. We need to provide them a psychological and spiritual support to these patients along with the family by a team approach. And this is what we are targeting as enhance or good quality of life, also a good death for these patients. And that is what is required for these patients. And when we talk about one aspect, when patient becomes terminally ill, end of life care, we need to continue the concept of good quality of life to culminate into good death also, because the patient may be bedbound, semi-comatose, difficulty in swallowing, eating problems, breathing problems. So we have to provide symptom support to these patients as well, so that these patients becomes much, much better at the end of life also. And that is what sometimes, if you see what we have discussed, what Madam Alice has discussed also previously, palliative care is something called care beyond cure. It's a low technology and high touch. You don't require sophisticated equipments or wards or ICUs for this. It just requires understanding of the patients, and wherein we add life to days and not days to life. We are not thinking of prolonging life in suffering. What we are looking is whatever the life is left, these patients should have a comfortable life so that these patients can get something from us at each point of time. Now, this was the chart that was discussing the journey. Now, the palliative care is just not the at the time of death of these patients, but now what we think is palliative care should be from diagnosis of a chronic disease in an integrated model, so that in case if patient is getting good curative intent, fine. But if patient is not responding, then the component of the palliative care, which you can see here, is increased, and the patient needs to be supported for these aspects also. So this is what I just mentioned, and this needs to be re-emphasized here, that the palliative care has to have an integrated approach, wherein, yes, you need to have some disease-focused care, but all patients receive comfort-focused care, not only from physical point of view, but also from other aspects, including social, spiritual, emotional. And the care should culminate into life to death, which remains good. And also you need to have bereavement for these patients. Now, palliative care setting, people ask, you need a center, you need a place. No, palliative care can be provided at any place, whatever it is, home, hospice, hospital, OPD, volunteer-based. And who can provide? Any patients can provide, any person who are trained, who have basic understanding of palliative care, they can provide it. Home care is one of the important aspects, because the patient becomes feels more comfortable while they're at home, but then you need to support them so that they remain symptom-free. They get the holistic care. The suffering is not being increased at home as as we were discussing earlier, that if somebody is not giving them good care, then it becomes an issue. So as a palliative care physician, we need to coordinate these activities so that these patients are comfortable at home, getting all the care that are desirable with good communications as well. Now, potential palliative care interventions, I just want to highlight on these issues. Yes, we say that we provide them a holistic care, but there are certain things when we think that the patient is on end of life, we should not be looking for keeping these patients in ICUs, on ventilators, on dialysis, doing resuscitation for these patients like CPR if they get a cardiac arrest, because we know that this is an end of life. We are not going to do anything by keeping them on ventilators or IV fluids or total parental nutrition or some vasopressors. So we need to understand that if a patient is curative, yes, we do all those things. But if a patient is a palliative patient, we know that disease advanced. We should not be looking for those things which will increase the agony, and hence various interventions should be very thoughtful to given to these patients so that we are not increasing suffering. We are giving them a comfort care. The palliative care scope can be given to any age for any disease. Now, the number of disease in chronic setting is much more at any point of time, starting from the diagnosis. In any setting, it can get any place. There's nothing called a designated palliative care setting. You can give it any place, and it can be given by any person who has the basic understanding of palliative care, so that we can affirm life of these patients, promotes quality of life, treats the person, and supports the family, which remains the basic goals of these patients. And what we are looking for is improving the quality of life of these patients so that these patients lead a good, productive, happy life, culminating into a good death and supporting the family members as well. So thank you so much. And any questions or any points, we can have a discussion.
Thank you very much, sir. As always, it is the comprehensive one. And now the participants can pose the questions.
Sir, I've posted.
Sir,
So, Bhavna, you have posted, kindly clear the difference among end-of-life care, hospice care, and palliative care. So I said palliative care is basically an holistic care that starts from the diagnosis of a chronic disease. Many of these patients probably get cured, but if you must have seen these patients, even when they are being treated, for example, say cancer patients undergoing chemotherapy, they will have a lot of symptoms, physical symptoms. They will have a lot of social symptoms. If it's a breadwinner of the family, then they will not be admitted in hospital. Nobody will be earning for them. So this means the palliative care can be provided to any patients at any point of any point of the journey of their disease and its management. That is basically a palliative care. But when we say a palliative care, a disease is being taken care of. The patient is not responding to the treatment. Patient's disease is aggravated. The disease progresses. Patient gets a metastatic disease, and now we think that patient is not responding to any treatment. Then we say that patient has an advanced not responsive disease. Now, this patient will be having more of a palliative care or supportive care rather than the curative care. Now, since this disease, if further progresses, we know that patient gets a brain metastasis and patient is now bedridden, not moving around. And we know that patient is not going to survive for a couple of days to hours or months. Now, these will be patients where we say it is an end-of-life care, because we know that patient is in a very sick situation, advanced cancer, advanced stage, it becomes an end-of-life care. So these are the parts of the palliative care that I have just discussed in one of my slides. And hospice care is basically those patients. Hospice is not so common in India, because in India we have a lot of joint families. Family members are able to take care of these patients well at home. But at places where the elderly patient or the patients who are living alone, they don't have care at home. They may be admitted into hospitals where they don't get, they are not provided something called as curative. They are not ventilated. They are not putting on ventilators. They are just provided the care which is under the ambit of palliative care or supportive care. So these type of centers are called hospice care, and they are being given to patients who do not have the facility to be taken care by the family members at home. So this is the basic difference.
Sir, in this
Regarding
co-
the
in
ethical
this
conflicts, yes, Bhavna.
Sir, in this hospice care, both the population will come, the palliative care covering population as well as the other population, end of life care. Both the population are coming under the hospice care, sir.
Palliative care is the umbrella word. Palliative care is the supportive care that you provide to any patients, curative or end of life. End
Yes,
of
sir.
life is one of the aspects of palliative care.
Yes, sir. And sir, the hospice care. In
Hospice
this,
care, I said.
sir, in hospice care, the curative patients will also come. Those who are responding to the treatment.
Hospice, I said hospice is where the patient does not have facility to be at home during the end of life. Those patients are kept in hospice. So this hospice is not for curative care because they don't provide ventilators, IV fluids, they just provide comfort care. So that is called as hospice.
Oh, okay, sir, got it. And sir, next question was the ethical dilemma, sir. How to deal with
There is
it?
no ethical dilemma. If you understand the things well, we have a good communication, which Madam Alice also said, and the initial dignitaries also mentioned. There is nothing called ethical dilemma. If you remember the 4 basic principles of medical ethics, if you remember those medical ethics principles, I don't think if you understand the disease well, if you give the goals of care to these patients well, if you communicate them well during the disease progression, I don't think there is any ethical conflict or ethical dilemma. You have to now communicate the disease process, the treatment process, the futility of the treatment or the interventions. So once you start doing it, I don't think there is any ethical dilemma.
So the most common is like if the relatives, they don't want us to let us know the patient that he or she is suffering from that advanced cancer and all. So in that situation, what we need to do, sir?
I think this is called collusion when because of the love and affection, the family members think that the disease should not be told to their family members because they will not be able to tolerate it. I think this needs to be on individual basis. You need to have a rapport with the family members and the patients. Patient is smart enough to understand if some patient is coming to a cancer hospital, he knows that he is having cancer. If somebody is visiting a cancer surgeon, a cancer hospital, he is not coming for treatment of tuberculosis. Even an illiterate person will understand that this is a cancer hospital. So the patients understand them, but sometimes they do not speak. So you need to have a good rapport with them. You need to have good communication with them. And then with time, these diseases can be disclosed so that the whole family is in the same platform. Think of a patient who is having a terminal disease. He wants a treatment. Who does not want a treatment? If you have a pain, you like to get it treated, right? And we say it's a temporary pain, it should be treated within a day or two or within a week. If somebody is having a continuous pain, some problem, and you are not getting it cured, they will lose trust in the family and the doctors. So they need to understand that they have advanced disease so that they can plan their future. They can have some the unmet works or undone works which they want to complete. So that needs to be done in a communication. But the communication, there is something called breaking the bad news. It's a complete session wherein you should be very, very clear and cautiously, not making the patient and the family member hopeless. And that is what we do very sequentially so that these can be understood by the patient, the family members, so that everybody is at the same platform. So this is doable.
Thank you, sir.
And sir, if you permit, just to add, even one day in hospice is almost equal to 1 week in life for the patients. That is also being told. And we have already seen that so many patients with bad prognosis and 15 days bad prognosis and all, but they lived in the hospice care for about 2.5 to 3 years because of the best possible care being given for the patients, which they were not deprived of, being the destitute patients. So that kind of things are also there. So hospice needs to be promoted and propagated, because still that misconception is there that it's why to keep in a hospice. So that can be. And doctors
Thank you, sir.
already told everything in detail. And that person, it should be person-centered, and that person-centered goals of care that is required. Because when we are going to a patient, especially in the home care scenario and all, the patient is, this is a real patient-centered. Instead of him reaching to the hospital and one among the so many patients anxiously waiting for his turn for the required intervention by the hospital, just like any guy with a spinal injury and all requires catheterization every 21 days or 15 days as per the medical protocol. And if the patient is staying on a fourth floor or something like that in a flats, and he has to be brought down and then took to the hospital and waiting endlessly and anxiously. Instead, the nursing fraternity, one nurse and one volunteer with that catheter, that also if he cannot purchase, that also purchased and gone to the that patient's home, there that quality of life of that patient improves. Instead of his coming all the way to the hospital and waiting endlessly among all patients. So that kind of things are already there, and that is the home care and hospice, everything sir has already mentioned. And he has also talked about the good death, and all other speakers are also told that that misconceptions of this thing, palliative care that needs to be. Just for example, one patient we have met about 8 months back. That patient, when we went there, he was having a big bed sore, and somebody has told the patient's wife that the bed sore happens at the end of life. So this patient, hemorrhage patient, since 2017, and the only wife was there only to care for him, and the tempo of care the wife was doing has completely came to a standstill when it has been told that the husband is at the end of life, because see, the sign is this bed sore. So that kind of misconceptions, that we, all of us, whosoever serving in the public health, we can remove those kind of things. And then when we could intervene, and now that the tunnel type of bed sore is just like a mark only, that scar only, just like that. So now that the tempo has been taken, I mean, it has come back to the wife, and she thinks that no, my husband is there for me, though he is lying on the bed. So that kind of intervention will give real quality of life to the chronic patients. And before I invite our next speaker, if any other question is there to Dr. Ragesh sir, because Ragesh sir is there in All India Institute of Medical Science, and All India Institute of Medical Science, you know, every kind of patients end up there. With from the all adjacent states as well as from the distant states. So sir's experience and exposure and the clinical experience, that is immense. So if any more questions is there, it's better to catch hold of sir right now, or we can go to the next speaker. So if any question, any more questions?
Good morning, sir. Sir, I am having one question, sir. When the patient is in the advanced stage, so the hospital is discharging the patients to the home. The patient is suffering with severe pain, but the hospital is not ready to prescribe any opiates. So how can we handle that situation, sir? The patient is suffering with the severe pain on last stage.
Am I audible?
Yes, sir. Yes, sir.
I think that is, we are creating or having these type of programs to create awareness, because these type of symptom management, you said about physical symptom, which is pain and prescription of opiates. I think these type of programs are required to be taken care across India. And there are a couple of programs which are under the ambit of teaching training program of certificate courses, IPC also. So wherever these hospitals are, if they don't have this type of trained physicians, if they are created an environment and awareness, they can have these type of facilities in each hospitals. And I'm sure that the any patients will not be devoid of giving these type of care. So we need to create awareness. You can talk to the hospitals concerned, and once they are sensitized, like this type of awareness program, once they are sensitized, they will take care of these patients more effectively. And I think that will be the day we are looking for in future.
Thank you, sir. Sir, when we are approaching to the any physician in the local area, there also is not ready to prescribe any pain medication, sir. They are telling that no, we should not prescribe this medication. Like that, they are avoiding. So we have to sensitize all the medical officer also.
You're right, sir. You're right, sir. We need to sensitize the people. We need to get trained for prescribing opiates also, so that people do not misuse them and they use them appropriately. They should have some training also, so that the prescription for pain management by opiates by WHO Letter 3, they will be able to take care accordingly in a way that these patients are not harmed. These patients, because all these drugs do have side effects. So basic minimum training is required. And that's the reason, due to the lack of awareness, they are not able to prescribe these patient medicines safely. Once we start creating awareness, we can have some training programs for them also. Once they attend the training program, they will be able to take care of these patients more effectively.
Thank you, sir. Thank you very much.
Thank you.
Thank you very much, sir, for sharing your deep knowledge about what is the palliative care and the need of the palliative care to the society with us. Your session was full of enthusiasm and valuable knowledge.
To know more about palliative care, we have amongst us an expert, Ms. Anu Savyothelli, nurse consultant, Department of Palliative Medicine, Mahatma Gandhi Medical College and Research Institute. I kindly request Ms. Neha Mishra to introduce our speaker.
It is a great opportunity for me to introduce Madam Anu Savyothelli. Madam is a nurse consultant in Department of Palliative Medicine in Pondicherry. Madam Anu Thelli is a nurse specialized in palliative care. Madam has completed her BSc Nursing at Pushpagiri College of Nursing in 2010, Kerala, and MSc Nursing from the Narayana Rudhyalaya College of Nursing 2012, Bengaluru, and underwent training under the Institute of Palliative Medicine, Calicut, Kerala. Madam moved to Pondicherry in 2014 to set up palliative home care services for Sanjeevan Palliative Care. Madam joined Mahatma Gandhi Medical College and Research Institute to set up palliative care services. She is also a faculty for palliative care nursing for the Indian Association of Palliative Care and Indian Institute of Palliative Medicine and many more. I request you, madam, to share your expert view on the topic. Over to you, ma'am.
Good morning, everybody. I know that, like, we are rushing the time, and thank you for thank you for introducing me. I'll just try to wind up, and I'll take up all your questions because you have learned so much from today morning onwards. So I'll just wind up what we have already learned. So you all have seen sick patients, and just if you all those people who have chat, can you just put up what are the causes of suffering that you have seen in your sick patients? So far, somebody have discussed about pain, suffering, cancer pain, discomfort, sleeplessness. Thank you. No. Emotional disturbances, constipation, exactly. So from the morning onwards, I have been listening to all the classes. Now you know, like was a palliative care nurse, what she's supposed to do, and as a medical fraternity, palliative care, what they are covering, doing to cover the symptoms, how to support the patients who is seriously ill or terminally ill. Now, just few things that I really want to add to it. First of all, palliative care is provided as a team. And as nurses, we play a major role in providing palliative care. So already many have discussed who are all there in the team: patient, registered nurse, social worker, pharmacist, volunteer, psychologist, dietitian, patient, family member and other loved one, spiritual advisor, and community health worker. So among the team, if you can see, maybe registered nurse or volunteer. In most of the cases, the registered nurse is the only person who is going to be in touch with all the other members in the team. So that is why I always, stress upon more people more nurses coming into palliative care, or more people getting specialized in palliative care, because we have an acute shortage. Also, we have a huge demand. This has already seen. Again, for the students, just to understand, because I heard somebody asking about end of life care or hospice care and things like that. See, hospice care is a type of care given to patients who will be dying in another 6 months. Or we are sure that they will be the death will be there in another 3 or 6 months. But palliative care is a broader term. Palliative care can be given to any patient who is chronically ill, but that doesn't mean she should die today in another 6 months or another couple of 1 year. See, stroke patients, hemiplegic patients, they may die another 30 years. There are so many, like cardiac failure patients. Like some people may live for 3 or 4 years. Sometimes, especially when we take HIV patients, they can live for many years. So, but they require some support, where, like, for pain management, for symptom management, to deal with the side effect of medications, or sometimes, for stroke patients or hemiplegic patients, to remove the catheter, reinsert the catheter, and things like that. So they require palliative care, but that is not hospice care. Hospice care is mainly for patients who are in, facing death, the end stage. And we also provide bereavement and grief support. So that is another area, palliative care nurses can be versed trained in grief and bereavement. And as a follow-up, again, nurses have a major role. So you have already listed few things, like, say, suppose you imagine a cancer patient. They have pain and other symptoms. Psychological issues are there. Most of the time, you will not have a backup of psychologist or psychiatrist. Then again, if patient is sad, anger, worry, who will be there to support? Again, palliative, a trained palliative care nurse. So I always stress this word training, and I will, at the end of my slide, I will explain where the training is available. Spiritual distress, like why me, or why God is punishing me? All these questions, to whom the patient will ask. I am almost sure that the patient will ask most of these questions to the nurse, the caring nurse. Social needs, basic needs of the patient, like debt, money problem, financial issues. Again, the patient will be sharing these things to either volunteer who is coming to help them or the nurse most of the time. So this has already been explained, but again to stress, some of the patients, some of the conditions are cancer, neurological illness, end-stage lung disease, HIV and AIDS. And now we have a very growing demand for children with congenital anomalies and genetic conditions, very premature infant, pediatric palliative care, children with cancer, and perinatal palliative care, all these congenital anomalies syndrome. And why do we want palliative care nursing? We have critical care nursing, we have pediatric nursing, we have maternity nurses. Why we need palliative care nurses? See, first of all, it's almost sure that one or the other day, everybody will have to face death. Or most of the patients, most of us may have receive a diagnosis of any form of chronic illness, and some unlucky people may get serious terminal illness. So understood, when you take a population, this is almost for sure. So we require trained palliative care nurses. And see, most of the time, even I as a student, when seeing somebody who is terminally ill, my first doubt is like why this patient is not taken to ICU, why the patient is not provided ventilatory support and things like that. So most of the nurses are not prepared to deal with death. Nurses are frustrated. And this happened when I was doing post-graduation. I knew that the patient will die. I know that doing a shock or doing resuscitation is not going to help. Then why again I am doing and I am breaking the ribs? So getting frustrated with futile treatment. Palliative care and versus hospice care is not very well understood among nurses. Patient and family will have so many unrealistic goals, like I want to attend my son's 10th, or like I want to see my son as a doctor, I want to see my daughter's marriage, many things like that. And you know that the patient will be dying in another 1 year or 2 years or maybe 6 months. So we really don't know how to tackle with these kind of unrealistic goals. Many difficult questions, why God is punishing me? And are we really taught how to answer these questions? Most of us, I will say no. Collusions, as Stella Madam said, very difficult to manage, but we have to manage for the betterment of patient. But are we trained to manage these collusions? Again, no. Resilience, most of the time we have compassion fatigue, burnout, and how to deal with all these things. Are we taught resilience? No. But in palliative care, all these aspects are well clearly taught. And already mentioned, palliative care and hospice care. Palliative care is mainly with physical and psychological relief, focus on quality of life. We know that the patient may die, but not very soon. So our thing is to improve the quality of life. So this is again multidisciplinary team approach. This is at any stage, whereas hospice care at the last 6 months or less, maybe concurrent with curative treatment. So here palliative care goes along with chemotherapy or radiation therapy. Along with that, palliative care also go. But the other one, usually curative care is not there. So where and all we can provide, as Sir said, anywhere, patient home, nursing home, assisted. 1 second. Assisted living, hospice, hospitals, primary care, community-based facilities, and medical colleges. Why again I need to stress, now palliative care has started being provided in all the public care sectors. So again, we need more trained palliative care nurses. So what nurses can do? Like Madam said, we can provide guidance and support, adequate information, break the bad news, clarify concerns and problems, provide emotional support, set realistic goals, refer to social services, help in making decisions. Everything, most of the things are done by palliative care nurses. So now coming to the main part, where these training programs are being done. I saw this question in the chat box too. There are so many webinars like this happening across India. And there are half-day programs. Apologies, I have twins. They are very sick. And there are one-day programs which is certified as a sensitization program. Foundation courses in palliative care nursing, which usually happens either as 3 days or 3 a day with practical or a 10-day full stretch. This is happening in Pallium, India. Certificate course in palliative care nursing. This is actually the basic program. The other all other programs are just training programs. But to be known as a certified palliative care nurse, you should get enrolled to 4 weeks to 6 weeks, either CCPN or BCCPN. BCCPN, this is certificate course in palliative care nursing. And there is 1-year fellowship in palliative care nursing, which is happening in IPM. And there is international fellowship in palliative care, again with IPM and St. Christopher's in collaboration with St. Christopher's UK. And certificate course in essentials of palliative care conducted by Indian Association of Palliative Care. I think the next batch is going to start very soon. This is an online program, and there is examination also. And there are ELNA courses happening, 3-day program happening across so many places in India. I am not so sure whether we have time for a story. Because it's 12:30. If it is there, we will stop it, and I really want to answer the questions. Scope exclusively for palliative care. Ma'am, you want me to talk about palliative care nursing?
Yes, madam.
The current shortage is, an acute shortage of palliative care nurses. We really don't have more specialist palliative care nurses who can take up, because most of the centers, home care per se is taken up or led by a palliative care nurse. So if you take medicine or surgery, the team will be led by a doctor usually. But I think only in midwifery and palliative care, the team is led by a nurse. So we have this acute shortage. So that is a major part. And we now currently palliative care and rehabilitative, collaborating, and pediatric palliative care. It's another upcoming. Perinatal palliative care, those people, stillbirth and things like that. With that, geriatric palliative care is another area of focus. And like if I say now, I am focusing more on transgender palliative care. So there are, days pass by, there are several issues coming up for a palliative care patient, for a geriatric patient. Healthy aging is coming up. So people are getting aged. What are the supportive care needs that they need? So the scope is, high. The demand is so much, but as I mentioned, the shortage is very severe. This is a problem not only in India, across the world. One second. Bereavement, after being certified palliative care nurse, job description, government post. See, now Ayushman, through Ayushman Bharat, the services, palliative care is included in the services. So we really, and in government services, I think there are government hospitals like AIMS have palliative care services. Most of the AIMS have palliative care services. I think Tata has, in coming to Pondicherry, Jipmar has a central government and state government centers. In Kerala, all the state government hospitals also have palliative care services. So per se, I am not so sure about, getting as a palliative care nurse, but services have started. But who they will recruit is purely their purview. Obviously, if you have a palliative care additional qualification, they will consider for it. Tell about bereavement phase. Bereavement is very complex phase. some people cope it with very, very nicely. One second. Okay, some people cope it with very well, but some people will go into depression, especially when there is a very poor social support. One second. I'm sorry, my son is troubling. So some people will end up in serious issues like depression, or like they cannot accept the reality. They will go on with the denial phase for a long period. Requires support of psychiatrists. But who will pick these patients? Only like we have a program, like after the death, we will follow up the caregivers for some time, especially if the patient is young, like 40s or 45s. Their spouse may have issues, their kids may have issues, especially kids will have a lot of issues with the studies. The memories are coming, they cannot focus on studies. Some people have fear, whether my father will get married again, whether my mother will get married again, what will happen if a new person comes. So there are so many issues like that. So as nurses, again, palliative care nurses, we are trained how to solve common problems and when to refer to a psychiatrist or psychologist when it is required. So many issues happen during grief and bereavement too. Share the experience in setting up palliative care. I have set up a hospice center. I have led a palliative care home care team and a full-fledged palliative care team in a medical college. I'm really proud to say that. The experience is very much different because in the hospital, they appointed only a palliative care nurse, and I have to, there were no doctors even currently. So I have to go to all the departments, surgery, medicine, pediatrics, anesthesiology, and request one doctor from each department to join the palliative care team. And then we train all the team members in palliative care, and then we have a hospital palliative care team in our hospital, and one of the real good team across India. So that is different. And in community, it is setting up for palliative care in a community, you have to understand the community and you have to understand their beliefs, the social norms, and you should know how to approach, because they are the people who is going to think whether they have to accept or disapprove you. So first you have to keep community in front and community as the focus. That's a big experience. Experience sharing itself may take another 30 to 40 minutes. I really don't want to take your time. Anything else? The training venue. Most of this across Delhi, what are the centers? I think Suresh sir or Hamza sir can provide you all the details. But when it comes to this CCPN, I don't think CCPN is happening in northern part. So basic training is happening in 2 WHO collaborating centers. In India, we have 2 WHO World Health Organizations collaborating centers are there. One is IPM, Institute of Palliative Medicine, Calicut, Kerala. One is Pallium India, Trivandrum, Kerala. Both are in Kerala. So the national fellowship is in IPM, whereas certificate course in palliative care nursing. So the CCPN and BCCPN is happening in both IPM and Pallium India. Fellowship in palliative care nursing, the 1-year program is happening in IPM. So 1 year is distant mode. You have 20 days of placement, which you can do in Delhi also. But there is another 10 or 10 days of class, which you have to be physically present in IPM. And the international fellowship is purely online. I think this year's is closed. Applications are closed. So the application is invited usually in the month of October, November. And you be in touch with Hamza sir and Suresh sir, because they will be receiving all the updates. So as nurses, I urge you, I request you, because we really want more champions and more palliative care people across India, nurses in India.
Thank you very much, ma'am, for your interesting session and sharing your reflective knowledge on scope of palliative care.
Thank you so much.
I request our moderator, Mr. K.V. Hamza, General Secretary, DNIP Care, for summarizing all our topics and share his experience on palliative care.
Thank you. Thank you very much. And it's the palliative care when we speak about, it's not that 20 minutes or 30 minutes that happens exactly. The trainings about which Anu has already talked about, that is specifically for the nurses also. So that is very important, that we have to understand even the basic training for of palliative care for volunteers, not even the nurses, the normal volunteers also. It is about 16 hours, and out of which maximum time is on communication, which everybody has talked about. So it is not, though it is not a rocket science, it is definitely a subject which needs to be learned seriously and with dedication and commitment. So if just to sum up, actually the madam Achila madam, ADG nursing, has while talking, she has talked about global need of palliative care, as well as at the same time lack of
Sorry, sir, we are not able to hear your voice. Technical people, please kindly connect Mr. K.V. Hamza.
Yes, ma'am.
Sorry for the technical issue. Sir will be joining us soon.
I request all the delegates to fill the post days as soon as possible.
Now, I would like to invite Professor N. Sriram Sir, Vice Principal, SV Bicon, Silvassa, kindly to come on the board and deliver the vote of thanks. Over to you, sir.
Thank you. Respected guests, dignitaries, speakers, faculty, and delegates. Good morning to all present here. On behalf of the College of Nursing, I take this opportunity to propose vote of thanks to those who have directly and indirectly contributed to the virtual national campaign on palliative care. First and foremost, I thank DNIP Care and the Nursing Scholars Society for providing the facility to conduct this program in our institutions. We are thankful to Mrs. Achila Kumar, Director General Nursing. In today's program, in spite of her extremely busy schedule, has found time to inaugurate this program. Thank you, Madam. I thank our special guest, Professor Dr. Vimala Kabur, Madam. We are really enlightened with your knowledge and presence, Madam. Thank you, ma'am. I extend my heartfelt thanks to Mr. K.V. Kamza, DNIP Care, and Dr. Alka Dante, Secretary NSS, for all the support you have extended in making this occasion a successful one. Thank you, sir and madam. I would like to thank our combined speakers, Dr. Rakesh Kark, Additional Professor, for enlightening us with his knowledge. And today's virtual campaign was full of knowledge and interesting things. It gave deep insights into palliative care and also revealed some interesting facts. Thank you so much, sir. I'm pretty sure the precious knowledge that Mrs. Alice Stella gave us will definitely help us to overcome the challenges and rendering high quality nursing care services to clients. Thank you so much, madam. I would like to thank Ms. Anusevio Telling, nurse consultant, for making the excellent presentations and making this campaign interesting and meaningful. Thank you, madam. I would also like to thank our principal, madam, Professor Neeru Kumari, for her enthusiastic support. Thank you, ma'am. I am grateful to Mr. Suresh, Secretary of DNIP Care, for his enormous cooperation in the organization of this event. Thank you, sir. I am happy to express vote of thanks to our organizing committee of our college, faculty, staff, and first year MSc students who have made this campaign great successful. I would like to thank IT department who have been running around doing a lot of things for making this campaign great success. Finally, wonderful participants who have turned up in such a great number. They are totally 1,101 members are there, not only from our college and hospital, but also from other colleges and the departments. And thank you so much for your cooperation. Once again, I want to state that we all are most grateful to all in this occasion. We thank you for being with us in this morning. It has been a great pleasure. Thank you very much.
Thank you, sir.
I kindly request all the participants to fill the feedback form on your given on your chat box and WhatsApp group. We requested to all the participants on their video after the national anthem for virtual group photo. Thank you, everybody, including our eminent speaker, our invited guest, special guest, guest of honor, all our dignitaries, and all the participants. It was great pleasure to have you all on board. Till we meet next time. Kindly rise in your respected place in respect to national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा गंगा विंध्य हिमाचल यमुना गंगा जगति तरंगा तव शुभ नामे जाए तव शुभ आशीष मांगे गाए तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय 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 हे जय 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 जय
I kindly requested to all the participants on their video for virtual photo. Thank you very much, all. I kindly request all the participants, please fill the postage form and feedback form. E-certificate will be distributed in 2 to 3 respective days on your given email ID. Thank you very much again, all. Keep safe. Have a beautiful day. Now you can leave the meeting.